All right. Welcome, everybody, to our webinar today. You're meeting with me, Dr. Mary Clifton, and Ed LaCara, Dr. Ed LaCara. We're working together in his Dallas office, setting up a ketamine clinic and working on medical cards. But Dr. LaCara also has quite a bit of expertise in peptides, which I'm not sure I was aware of how significant this peptide experience is for people. There's a whole bunch of people on peptides now, 1 in every 8 Americans. It's become a huge experience for all kinds of people, and a lot of people are getting great benefits from them, including me. Ed has helped me with a stack that has been working great for me. So let's just dive into it, Ed. I'd love to hear all of your information about peptides and what are some of the reasons why people should be using them, and specifically how we can help people. So thank you so much for having a webinar with me tonight.
Yeah, absolutely. Thanks for being here. So I'm Ed LaCara. I own Body Lounge Park Cities in Dallas, Texas. I have a presentation to kind of go through looking at some of these more popular compounds. I will do another one next month as well, where we're really looking at some of these stacks, but I really wanted to get into the, kind of like, what is a peptide? How is it different than a protein? What is it kind of doing to the body and to our system? And then if any questions come up from there, then we can always divert. I'll share my screen. All right, so we're gonna kind of talk about, like, one of the biggest, I think, that makes peptides so interesting is that there are these little, most of the peptides that we're using or we already make. So I kind of think of them almost as like mini hormones. And just like hormones, as we age, we stop producing as much. And so me at 50, almost 3, compared to when I was 18, I have a slower production of things like testosterone. And so I augment that because I want to feel and look more like I did when I was 18 than I do at 53. So I just think peptides the same thing, that there's these little keys that can unlock certain things in the body to help us either feel better, get inflammation down. I use different peptides for shrinking a prostate. I use different peptides for getting somebody tan before they go on holiday so they don't burn that first day when they fly to Hawaii. I use peptides to help people improve their body composition, lose visceral adipose tissue. I use peptides to help patients put on muscle mass. So there's just tons and tons and tons of peptides. And I'll kind of talk about my thought process about how to prescribe and how to work kind of backwards and then how to rotate those. Because a lot of my patients, we just rotate them every 6 or 8 weeks, depending on what the goal is. We rotate the peptide. And there's reasons for that I'll kind of talk about. So this is me. If you ever want to get in contact with me, these are some of my social handles. There's my email address. You can always reach me at the clinic. But we probably about half my day currently is around peptides and peptide therapy for different things. Of course, I do have to say, because I don't know people personally on this webinar, that I'm not doing this as medical advice. It's only educational purposes only. You should really, before you start any type of peptide, you should get with your healthcare provider. They have an intimate understanding of you, your body, your labs, what your goals are, any contraindication, any of those things. Also, we should also emphasize that not all peptides are the same. You want to make sure that you're getting your peptides at a reputable either pharmacy or compounding pharmacy or manufacturer like we do. They should be tested, they should be pure. But unfortunately, there's been some findings that some of these websites that are just popping up, everybody's trying to jump on this peptide train. And so people are purchasing white labeled peptides from China. That's primarily where they're manufactured. And then when you test them, they don't come back as actually being what they say they are. And then there's other things in there that we don't want. Very similar to how nutraceuticals are. Always buying nutraceuticals like vitamins from reputable companies because you just don't know what's in them if they're not tested and regulated. Everybody really knows peptides like these GLPs. We started doing back in about 2020. We started with Semaglutide, the GLP-1, got great results, and it kind of like steamrolled into all these other peptides that we can utilize today. They're saying that that the amount of people taking peptides, especially like GLPs, are going to triple by 2030. So lots of people still haven't tried them. Some of them will be starting to be covered by insurance and will be used in different health conditions like cardiovascular disease, where it's right now being, if there is incidences of high cholesterol and high blood sugar and things, it's one of the first go-tos now is to use a GLP to get weight down. And what I see is when we use GLPs is we see great improvement in lab markers, decreased visceral adipose tissue, decreased insulin sensitivity, or I should say improved insulin sensitivity. We see better cholesterol markers, better hemoglobin A1C markers, which is a measure of your 60 to 90 day blood sugar, better insulin, most everything improves. So although most of the impetus is to try to get some of the weight off, for me, it really helps to improve somebody metabolically and improve their health. So what is a GLP-1? It's a glucagon-like peptide 1. It's a gut-derived hormone involved in appetite regulation. It slows gastric emptying to make you feel full a little quicker so you don't eat as much. Helps with blood sugar regulation and improves kind of a fullness signaling. These are really signaling hormones. So we're increasing, they call it a glucagon-like peptide, but it's a GLP, it's an agonist. It's signaling to increase the release of this peptide, and the results are pretty clear about how effective they are in weight loss. But interestingly, I just wrote a white paper on, I looked at the literature on how many people when they start a GLP, how many finish at before getting to goal weight or whatever their goal was with jumping on that GLP. And about 55% of people stop using a GLP within the first 90 days before meeting their goals. And a lot of that is due to basically inappropriate dosing. One of the things that was released when we first started doing this GLPs was that the GLP dosing was very strict. It was, you do, with Semaglutide, you do 0.25 milligrams the first month, and then everybody increases to 0.5 the second month, and then they go to 1 the third month. What we have found over the last 5 or 6 years is that people don't need to increase like that. People are losing a pound and a half a week, which is plenty. And you don't need to keep bumping them up like that. Bumping them up would give them those side effects like gastric distress, like diarrhea or constipation, regurgitation, things that we just didn't want. And so really being cognizant with dosing and individualizing that to people is important. I think that's one of the reasons why we have really good success with it, because we make sure that you're only using as much as you need to get the job done. That also prevents people from plateauing on it. They typically will be able to be on it for longer periods to get to their goal, whatever that is, either body fat percentage or specific amount of weight loss. So these are kind of the things that we kind of talked about and some of the literature around it and about what it does. People know GLPs primarily as Ozempic. There's other ones in the pharmaceutical market, essentially telling your brain that you are full. What it normally takes between that signaling from your stomach to your brain is it takes about 20 minutes without a GLP. And so what happens is you end up eating more. That's why you'll eat more than you typically need to, and then you could feel full later on. That's why Thanksgiving is kind of painful, right? It tastes so good, you want to shove as much stuff down there as you can, and it hasn't. You haven't gotten that signal from the brain like, hey, I've had enough. And so this helps that to make sure that we're signaling early that you are full. So it affects the pancreas, affects the stomach, and it affects the brain. And so you're getting not just the effects of what's happening with food and your relationship with food, but we also see a lot of other effects as well, like decreasing the need for SSRIs or depressant medication. People saying they don't need as much ibuprofen or Advil for joint pain. They feel a lot of times patients will report that they're feeling more cognitively alert. And I don't think that that's because of the GLP. I think that's because you're managing blood sugar much more effectively. You're not eating as much. And so you get these, it really has shown me how much sugar is the problem in Western society, where we typically will eat way too much sugar or carbohydrates, which drives insulin and then really plays havoc on the whole system. And so what's really happening is we're trying to transform the body into being more efficient, burning fat more throughout the day, changing our brain around how we communicate to ourselves around what food is and what that relationship looks like, and how much food do I actually need at 180 pounds and 5'10". I don't need as much food as I did. I can keep my portions lower much easier. With cutting your calories, though, what people have reported is losing a lot of their muscle. And that's why we emphasize that people must be lifting weights when they're on a GLP, because they need to maintain that muscle mass. The two really good ways to do that is lift heavy weights and also eat a lot of protein. And that helps us preserve that muscle mass that typically takes so long to build. And so we like to measure the muscle, measure the body composition through a DEXA scan before we start a GLP. A DEXA scan is the gold standard when it comes to measuring body composition. It's a light X-ray. It does a scan. It takes 6 minutes, but I can differentiate your bone density. I can differentiate your lean mass versus your body fat. And it's very, very accurate. Doesn't depend on when you ate last. Doesn't depend on how hydrated you are. Those are the numbers. And then especially concerning is the fat that's around our organs, or that visceral adipose tissue. Well, the DEXA accurately measures that. And now we have GLPs that target that visceral adipose tissue. The visceral adipose tissue is really the dangerous fat. That's the fat that makes us less metabolically active. It makes us more insulin resistant and plays real havoc on the overall system. So we want to identify that and then be able to measure the reduction in that visceral adipose tissue and all the adipose tissue, but also make sure that we're maintaining the muscle mass. So I typically will recommend people will do the DEXA once every 6 months or so. And then, because there is a little bit of light X-ray there, so we don't want to we're not doing it every week. We're not doing it every month. And then just do a comparison of the DEXA with whatever scale that you are currently using. So you know, compared to the gold standard, what your scale is saying. So the systematic reviews suggest that GLP associated weight loss also includes fat mass reduction. It's impossible to lose weight without losing some lean mass. So, the best you can basically do is, if you're going to lose 10 pounds of overall body weight, basically the best you can do is 9 pounds of fat, 1 pound of muscle. It's impossible to lose 100% of fat. If you're just going on a low caloric diet, not lifting weights, not focusing on protein, it can be as high as a 50-50 ratio, 50% fat, 50% lean mass. So by the time you've lost 10 pounds, 5 pounds of that is lean mass. That's not what we want, because when we get off of the GLP, now because you have less muscle mass, you have a lower metabolism. You have a lower metabolic rate. And so muscle is very important at utilizing blood sugar. It's very important at protecting our bones and our movement and our longevity. So we want to keep that muscle as much as we can. And I think that's the real reason for this slide is that GLP should not be viewed simply as a weight loss medication. It should be a metabolic optimization tool, and it's a tool as part of a healthy diet, healthy exercise, including high intensity training or heavy weightlifting and high intensity interval training at least once or twice a week, which is basically intervals, high intensity intervals, trying to get your heart rate low. And by doing that, you also help to burn that visceral adipose tissue, but it also is good for your cardiovascular system. We will stack these GLPs with other things if we're trying to put on muscle mass. So if we're trying to put on muscle mass at the same time as you're losing weight, it can be very difficult. So we can use different peptides to try to increase your muscle mass while you're losing that body fat. One of my favorites is called MOTS-c. MOTS-c is a peptide that it's basically working out in a bottle. It's stimulating the mitochondrial cell, increasing cellular turnover, and can essentially help you build muscle mass at that same time. So the three GLPs that we use, the GLP-1 was the originator, that's semaglutide. GLP-2, which is a dual, and they call it a GLP-2 because it's a dual agonist. It's still a GLP-1, but we call it a GLP-2 because it's a dual agonist. It does a GLP and GIP. Much more tolerable than semaglutide is tirzepatide, the GLP-2. It much less side effects and better weight loss. And then the most recent, it's been pretty popular in social media the last couple of weeks because Eli Lilly just released a study, is the GLP-3, which is a triple agonist, Retatrutide. All these are injectable. I haven't had much success with oral GLPs for weight loss. Maintenance, possibly, but for the most part, I haven't been really too thrilled with any peptide orally except for BPC-157, which is basically can help heal the gut when you have like gastritis or you have ulcerative colitis or you have an ulcer or things that needs to be healed from the inside. Another muscle preservation stack, you can use a growth hormone secretagogue or an analog, something that stimulates your own anterior pituitary to release more growth hormone. Ipamorelin is a really good one for that. It also can help to preserve that lean mass when you're trying to drop some weight. It also kind of focuses on weight around the midsection. So my patients that come in, they're perimenopausal, they've seemed to just kind of accumulate some fat around that midsection. Ipamorelin is a really, really nice peptide to target that. And then CJC-1295 and Ipamorelin also can help. So what you'll notice is that there's multiple peptides that kind of do the same thing. So what we do is we rotate them so they're not all going down the same pathway. And we don't stack these. We won't do a growth hormone analog with another growth hormone analog. You don't want your brain getting stimulated like that over and over again. So we'll rotate them and do them at different times of the year. So these muscle preservation stacks, basically the growth hormone releasing hormone is stimulated. The anterior pituitary releases the growth hormone. The liver then produces IGF or insulin growth factor 1, and then it helps with muscle protein synthesis. These are typically taken at night on an empty stomach, so a couple hours after you've eaten before you go to bed. It stimulates your growth hormone during your peak time of growth hormone release, which is usually between 1 o'clock and 2 o'clock in the morning, and can help people get into that deep sleep for longer periods of time. So people report improved sleep due to it. Some other ones that are very popular, BPC-157. I mentioned before, I use this with tendon and ligament for soft tissue healing. I will stack that BPC-157 with TB500. And that is what we call the Wolverine stack. I'm going to go over all these stacks next month, or the most popular stacks at least. But BPC is a really nice peptide, especially for musculoskeletal injuries. TB500 is a great stack with it. MOTS-c, I mentioned before, that exercise mimicking property. And then AOD9604, another mitochondrial signaling peptide, also mimics exercise at the muscular level. So this slide is just in here to kind of give you an idea of how often. These are all injectable peptides, subcutaneous injection using a very tiny, small insulin needle. Most of the time, we're going to inject these into the abdomen, rotating. Things like semaglutide or tirzepatide or retatrutide, Most people inject these once a week. I like to inject them 2 or 3 times a week at lower doses. You don't require as much through the week then. Also, it has a 5-day half-life. And so a lot of times patients would report that they inject themselves on, let's say, Monday, but by Friday, they would no longer be feeling the effects. And so what they would want to do then is increase their dose. And it was constantly having to increase the dose because they wanted it to last longer and longer. Well, instead, what I started to do about 2 years ago is started to inject Monday and Thursday or Tuesday and Friday. So we would split the dose or microdose. And what we found is that when you do that, you're not necessarily needing to bump the dose all the time. You, like I have people that are on the same dose throughout their whole course of treatment, and it might be at a very, very low dose, at like a starting dose, like a 0.25 milligrams once a week. Well, in this case, it would be once or twice a week, but that could even be split sometimes for some patients. So keeping the dose lower, in my mind, is always better. Always trying to, use the least amount necessary to get the job done. CJC-1295 with Ipamorelin, that's a mistake on that slide. Usually not 2 to 3 times daily subcutaneous. That's going to be Monday through Friday. Typically, we will inject those. BPC-157 can be done, especially for those musculoskeletal injuries, Monday through Friday. If it's an acute injury, I will do it twice a day, but at a little bit higher dose. So that's more of like an acute treatment. AOD is once a day, TB500 twice a week, subcutaneous. That's what SC means. And then MOTS-c is typically daily in the morning after a workout, appears to work the best. Glow Stack has a lot of popularity right now. The Glow Stack is essentially good to stimulate collagen and elastin properties, gives your skin really nice tone, increases hair thickness. So this is GHKCU, or the copper peptide, in combination with BPC-157 and TB500. So you're basically taking the Wolverine stack and you're adding the copper peptide. I will warn everybody that the copper peptide is spicy for most people, irritates the skin a little bit. And so by diluting it with BPC-157 and TB500, it's much more tolerable than just taking the GHKCU by itself. I know some people say they take the GHKCU topical. I haven't had great success with that. And so I typically recommend that it is injected. We want to make sure that we are focusing on the strength. We're focusing on that muscle mass while on these GLPs, and in trying to improve that strength. Clinical recommendations include baseline lab work, especially if you're going to take a GLP. We want to look at liver function. We want to look at kidney function. We want to look at pancreas. We want to look at insulin levels. We want to look at basically your blood count and your metabolic panel. I also like to look at IGF if you're using any type of growth hormone, secretagogue, or analog. I recommend with any of the baseline testing with some DEXA scan. I recommend everybody do a DEXA scan once or twice a year to really see where they're at accurately. Looking at that bone density. After about the age of 30, we no longer really produce bone, so without really heavy lifting. So we know we're going to lose bone, especially when hormones start to change. We start to lose estrogen and testosterone as we get older. That bone density is going to go down. So we need to see where that's at and address it. I do like dietitian counseling. I think that the peptides should be part of an overall healthier wellness plan. And then your exercise prescription, doing the high intensity interval trainings and the high intensity training, both of those 2 to 3 times a week to improve overall muscle mass, strength, fitness, cardiovascular health. So some key takeaways: GLP-1s have transformed weight management by improving appetite control, glucose regulation, cardiometabolic outcomes. The main concern is that rapid weight loss may also reduce lean mass, strength, recovery, and long-term sustainability. Body comp matters more than scale weight alone. The goals should shift from simple weight loss to lose fat, preserve muscle. Peptide stacking may help support muscle retention, recovery, mitochondrial function, and performance adaptation. And future care models will likely combine GLP therapy, peptides, resistance training, nutrition, and coaching for better long-term outcomes. And really, it's not future care. That's my care model. We use an app that patients will basically be able to record their activity, they record their weight, they record, and I'm able to view it on my dashboard. So when patients are coming in, I have a really good look at their sleep. I look at how much they're working out, how often they're working out. I can look at their heart rate variability, which is a measure of your nervous system. Lots of things that I can look at. And so it's not just a simple check-in. It's like, hey, how's this been going on? And I like to do that with not just my patients that are on peptides, but my patients that I'm managing their overall health.
That's, I think, a really nice thing that sets you apart, Ed, that you're going to be helping people with their overall health and helping to guide them in a healthier direction instead of just prescribing and thinking that weight loss equals the outcome, because people are looking for the weight loss. And that's fine. If all you're doing is looking for the weight loss, that's fine too. But a lot of people are also looking for overall health improvement, longevity, being able to be part of the welderly instead of the elderly.
Right.
So all of those other measures are also important to think about. What's the best way for patients to get a hold of you if they want to start a conversation? And do patients have to be in Dallas to work with you, or are you comfortable working with people in other parts of the country?
Yeah, no, I can do telemedicine with patients. A lot of patients will ask me to help them, even though they're getting their peptides somewhere else, and they're not local. And so I can do coaching that way as well. But that's what's the nice thing about my app, is that I can get people on the app. I can ship them a scale. Some patients I will ship things like if they have high blood pressure, a blood pressure monitor. I will ship them a glucose monitor to see how their blood sugars are managed throughout the day and night. Because everybody's a little bit different, so there's different things that I'm kind of looking for based on their health history and their risk factors and what their family history has to say about what they might be dealing with. So yeah, all those things can be done.
That's super helpful for people. And I think sometimes the prices are scary for people. But in a lot of cases, the reduction, losing 1.5 pounds a week is upwards of a 5,000 calorie deficit. And just thinking about how much food costs and how much it costs to consume and prepare 5,000 calories, it basically offsets the cost of the medication. In a lot of cases, the medication actually saves patients money with the cost of food nowadays, not to mention the costs that you're putting off on the other end of having diabetes and having to manage that, or dealing with joint pain that requires its particular management, including joint replacements. I've read some really great articles that were saying that fast food, impulse food places that sell food that people just buy on impulse, that people that do consume a lot of food, that they're worried about these products. And also that orthopedic surgery and physical therapy that support bad joints and the replacement of bad joints that often happens as you load the joints over years with excess weight, that as people adopt these weight loss approaches, it's going to be a lot less joint damage over time.
For sure. Well, to your point, is that a majority of those orthopedic are due to increased inflammation in the body. And a lot of times that increased inflammation is due to sugar and poor dietary choices. And so really thinking around, like, what do we need to be eating to reduce our overall inflammation? And it comes down to avoiding the sugars as much as possible. Now, of course, some people have sensitivities. I'm testing, food sensitivities all the time, because a lot of times people have this inflammation due to some sort of reaction to certain foods. But for the most part, it's that problem in the gut is normally a sugar issue.
It all is tied together. I think we spent a long time, much longer than we needed to when I first started in medical school, trying to figure out, what was causing high blood pressure or blood sugar irregularities or cholesterol. But all of the lifestyle modifications are causing all of those things at the same time. And the root is in modifying the lifestyle back to a healthy lifestyle that'll support so that those diagnoses don't become a part of your life. And these
Yeah.
are really good tools. A lot of people say a lot less inflammation, much more comfortable, like less pain if they're in chronic pain when they use a GLP-1. And you think that's also related to the sugar and to it. Does it have a potential direct anti-inflammatory effect?
Not that I know of.
Yeah, see, isn't that interesting? I wonder why so many people say they feel so much better on a GLP-1.
Well, I think it's because of the insulin release. You get this increased insulin, you're controlling the blood sugar better. You're not eating as much, you're not spiking it as much. And so you're not just sitting there in constant insulin. And, as you know, when you have this increased insulin, you can't burn fat. So you're basically just burning whatever the last thing is you ate until the next time you eat again. And so your body just never gets a chance, unless you're specifically fasting or doing other things, to do what it's really designed to do, which is burn fat. But unfortunately, the American diet sucks, and it's so difficult to even go in the grocery store, even if you stay on the edges of the grocery store, to find good food. And we're all so busy that now it's like, okay, well, where are we eating tonight? What are we going to pick up? And you just never know what's in the restaurants, and it's just so hard. And you travel all the time; it's nearly impossible, to find. It doesn't matter what type of restaurant you're going into; they always are going to make it taste good. And what makes it taste good? Sugar and salt and fat and bad fats. So that's a whole other story. When we go to Europe, we feel so much better. And why patients can go to Europe and be in Italy and eat pasta and bread and drink wine and feel great, not have any problems, come back, they didn't gain any weight. And I'm like, of course, because the food is so healthy and good, and they're only eating what is in season. They're not eating, I don't know when banana season is, but bananas from some other country because they've imported them and they're all manufactured. And you only eat tomatoes when they're harvested. That's it, because that's the only time of the year you should have a tomato. That makes total sense to me.
Eating with here is such a fun shift. That was a shift I did many years ago, and it's really fun to wait for the food when it's at its peak instead of trying to get strawberries every single week all year long. It's just better to try to eat according to the seasons, and then you get so much more orange food and green food in the winter. Lots of salads in the spring. It's fun. It's a nice way to transition your meals. I think a lot of people would benefit from more fasting. I always say that about our family, that we're old Irish potato famine people. And the people that survived the potato famine survived famine. They're better at starving than they are at overfeeding. And I would argue that over the course of our development, most of us are better at fasting than we are at overeating. Overeating is a really rare and very new phenomenon for our species, and we just don't know. Most of us don't have the genetics to manage overfeeding. That's just not the way we've been selected out over time.
No, and definitely not overfeeding and then sitting in front of a computer or being inactive. If we were overfeeding a couple hundred years ago, that was because you were out and you just got a kill, and it took you thousands and thousands and thousands of calories to actually hunt. And so you did a time of fast and then feast, but it took so many calories to do it. Now we just feast and sit. And so there's nowhere for that to go. And that's why I think it's so important to have the exercise program in place where you're doing things that are more challenging. You're doing things like running away from a bear, high intensity interval training, and long zone 2 training, and being cognizant about like, okay, how much do I really need to be doing? And those are just minimums. There's we always do better when we're pushing the envelope a little bit, not to get hurt, to push the system, because the system likes to be challenged. It doesn't like when it's easy.
All of that, very good advice. That's wonderful. Thank you so much, Dr.
My pleasure. Thank you for having me.
For
And then next month, we'll talk about all the stacks that everybody's seeing on their favorite social media.
That'll be great to go into the stacks in more detail and think it through. Wonderful.
Good.
Thank you, everybody, for joining us tonight. If you have any questions, you can direct them. Oh, thanks for the heart. That's great to get that feedback too. Oh, thank you, Kyle. All right. You guys have a great evening, and we'll be back next month with more information on the particular stacks. Thank you again, Ed, for joining us.
Thanks, Doc.